welcome everyone who is here in person and who's watching virtually on the platform live or later. We are delighted to be here and to start this spotlight session on local regional treatment, de-escalation in breast cancer. My name is Dr. Wendy Woodward. I'm a radiation oncologist at MD Anderson, and I'm honored to have the opportunity to moderate the session today and to help present these exciting posters. Our first discussant is Dr. Julie Bradley. She is an MD PhD from the University of Florida Health Proton Therapy Institute and a radiation oncologist. And she's going to be discussing poster 704, the avoidance of radiotherapy for low-risk breast cancer using Lumina trial criteria and accounting for endocrine therapy adherence, by Dr. Soul, who's here in person, I believe, and can be a part of the question and answer session afterwards. And 709, the safety of conservative surgery with a PBI reirradiation for isolated ipsilateral breast cancer recurrence, regardless of subtype. And that's by Dr. Espinosa Bravo, who is here virtually, I believe. For those of you who are watching live or later, the recorded aspect of the poster presentations is not playing during this 30 minutes, but will play in the virtual session in the recording to the best of my understanding. So with that, I will turn it over to Dr. Bradley for our first discussion.
Thank you, Dr. Woodward. Good morning. It's a pleasure to be here with you this morning, and I'm excited for the opportunity to present these two posters that focus on de-escalation of local regional therapy. And there's a number of trials that are going on in this setting, and it's really finding that optimal balance of a sufficient amount of treatment that our oncologic outcomes are at their maximal efficacy, but not over-treatment where we start to slide down that other side of the curve into the realm of unnecessary or unneeded toxicity. As Dr. Woodward mentioned, these are the two posters I'll be discussing. And the first looks at omission of radiation in patients with low-risk early-stage breast cancer. And there's several prospective trials that are going on in this realm. The Lumina, IDEA, and Precision are all single-arm observational studies, as is the Prime Time out of the UK. And then the expert trial is phase 3 randomized between omission of radiation or endocrine therapy with radiation. And what's unique about all of these is they're using a biologic selection marker, as you can see, varied across the different studies, to try to supplement our identification of low-risk, favorable breast cancers so we can appropriately cut back on therapy. Also recently, earlier this year, the NRG DEBRA study opened, which is similar to the expert trial as a phase 3 randomized study, a targeted accrual of over 1,500 patients, and eligibility age 50 to 70, a low oncotype, stage 1, hormone receptor positive. And in this study, radiation is standard of care, and that can include whole breast radiation, standard or hypofractionation, partial breast radiation, or accelerated partial breast radiation. So the abstract that's up for discussion this morning was done by our colleagues from Chicago, and it's a multi-hospital retrospective review. And they looked at charts from 2007 to 2016 and applied the eligibility criteria for the Lumina trial to their search criteria. And with that, they identified 115 patients who met the eligibility criteria for Lumina, and 84 of those were treated with external beam radiation, and 31 had omission of radiation, and all were prescribed endocrine therapy for 5 years. They looked at adherence to endocrine therapy, which they defined as completion of 5 years of endocrine therapy unless it was discontinued because of disease progression or recurrence or death. And endocrine non-adherence then was less than 5 years of endocrine therapy discontinued for any other reason. This is a table of the patient characteristics. So there's a slight difference in median age. The women who had radiation omitted were older by about 10 years. And there also was a difference in adherence to endocrine therapy, with those who did not have radiation having about 10% higher rates of non-adherence to the endocrine therapy. In terms of the median duration of the endocrine therapy, as expected, those that were adherent had the full 5 years, and those who were non-adherent had about 19 months as the median duration of endocrine therapy. Their 5-year local regional control for the entire cohort they observed was 100% for those who had radiation and 94% for those who did not have radiation. And then they looked at that as classified by endocrine adherence. And for those who were adherent to endocrine therapy, the local control was 100% in both groups. But for those who were non-adherent, the local control numerically dropped for those who had radiation omitted. It dropped to 83%, but as you can see, that did not reach statistical significance in their report. So their conclusion was, in this cohort of patients with low-risk breast cancer eligible for the Lumina trial, there was excellent local control in those who had, for those who had the omission of radiation, particularly when they were adherent to endocrine therapy. And we have the prospective studies that are accruing or completed accruing and waiting for results to mature. But there is a little bit of a red flag with a non-statistical numerical drop in local control in those who are non-adherent to endocrine therapy. And interestingly, in the non-adherent group, the local control remained 100% in those who received radiation. And they highlighted the importance of prospective trials tracking the adherence to radiation or to endocrine therapy, because what is recommended and what is actually done might not match 100%. And so I wanted to explore a little bit more non-adherence to endocrine therapy. And there's a range of reports in regards to how often patients are non-adherent to endocrine therapy. In this retrospective review of the Taylor-X population, they found that at 4 years, about almost 90% of the patients were adherent to endocrine therapy, so a 4-year non-adherence rate of 11.4%. This may be a somewhat specifically highly selected patient population, those that are willing to enroll in a randomized trial and being closely followed under the guidelines of that trial. Another study was a large review out of Kaiser Permanente that looked at over 8,000 women who were taking endocrine therapy for breast cancer. And they found that the rates of non-adherence as well as discontinuation combined reached about 50%. And in this study, the rates of non-adherence were higher with aromatase inhibitors compared to tamoxifen. So what are some risk factors, or who might be at higher risk for non-adherence to endocrine therapy? And there's quite a few single institution retrospective studies on this topic. Age has come up across a number of studies. In this study, it looked at the percentage of the time patients were taking endocrine therapy, so they used 80% as a cutoff. And younger women were less likely to be taking the endocrine therapy 80% of the time compared to older women. And they also looked at number of days missed in a row of endocrine therapy with a cutoff of 10, and younger women were more likely to have a gap of 10 days in their endocrine therapy. They also looked by race, and Black women had a similar outcome to young women, with about a 10% difference in less than 80% adherence to endocrine therapy, as well as more likely to have a 10 or more day gap in the endocrine therapy. Another study looked at adherence based on insurance type and found that there was a decrease in adherence for those who were on Medicaid or had a self-pay plan or lack of plan. And a study out of a nursing journal really sought to investigate the patient's perspective on this and found 3 main topics that arose from these interviews and surveys with patients. One is that patients expressed that they felt they didn't have an option, and this overwhelming fear of recurrence made them feel like they absolutely had to take it. But that was balanced by, for some people, that the side effects were worse than the fear of recurrence, and so this balance of quality over quantity of life. And they really felt that having more support and more knowledge of the side effects and more support to manage the side effects would be helpful with their ability to adhere to the prescribed regimen. Another study looked at types of communication that help support patients with adherence to endocrine therapy, and found that just telling patients about it was not as effective as having a conversation about it. So really that bidirectional communication and taking the time, how often, how are you taking this, how is it affecting you, and what can we do about it? Then switching to the next topic of de-escalation, moving out of the de novo setting for early stage low risk breast cancer and into the small proportion of patients who have an isolated local failure after an initial attempt at breast conserving therapy. And really the question is, can mastectomy be avoided in the setting of an in-breast tumor recurrence following prior lumpectomy with radiation? And generally, most would consider that mastectomy is standard of care in this setting, yet there is no solid data demonstrating that mastectomy is the superior approach. And patients with in-breast tumor recurrence, there's quite a heterogeneous group, size, molecular subtype, duration of time between the initial therapy and the recurrence, and all of those factors can come into play. Often these local recurrences are detected early. Patients are often coming in for surveillance and routine follow-up, and so technically a second lumpectomy is feasible. And the question really becomes about selection criteria. I think that's the theme linking these two abstracts, is for whom can we safely recommend a second attempt at breast conserving therapy? So the abstract looked at was a multi-institutional retrospective review conducted from 2014 to 2020 in Spain, and all patients had a prior lumpectomy and radiation, and all were at least 4 years out from the initial therapy. They identified 35 patients with a median age of 65. The median time between the initial therapy and the recurrence was quite long at 154 months, and majority had invasive recurrence, about 86%. They had a wide range of molecular subtypes with about a third luminal A, 40% luminal B, and about 10% each of the other molecular subtypes. All patients had a second lumpectomy and then reirradiation with accelerated partial breast irradiation, which was IMRT in about 2/3, 3D photons in about 1/4, and then a small percentage with intra-op radiation. And with a median follow-up of just over 3 years, there were 4 relapses total. Only one was a local recurrence in the breast, and that developed after an initially non-invasive recurrence. And then 3 patients developed metastatic disease, and the authors highlight that the molecular subtype for these patients was luminal B. It was not the triple negative or the HER2 positive. So this resulted in a 5-year regional free survival rate of 82%, 5-year metastasis-free survival rate of 85%, and a 5-year overall survival of 93%, with 2 deaths that occurred unrelated to the breast cancer. So how does this fit into the larger picture of data in this area? So there's several series that looked at lumpectomy alone in the setting of an in-breast recurrence after prior lumpectomy and radiation. And they found that the 5-year local recurrence risk was quite high, ranging up to 30% in several studies. And if we compare that to the outcomes after mastectomy, again, a selected series of mostly retrospective reviews on this study, the 5-year chest wall recurrence ranges from about 3 to 15%. So it's not 0 even when a mastectomy is done. And I think sometimes that may not always be clear made clear in the clinical encounters. And so if we look further at the data that's available for this situation, a second lumpectomy with reirradiation, there are several studies that are out there. Across these series, the second local recurrence at 5 years ranges from about 5 to 21%, but the majority studies 10% or less. A lot of these used brachytherapy. One used electrons, and then the NRG study used photons. And in the absence of randomized data, probably the closest that we have beyond these other single or multi-institutional retrospective and prospective reports is a study from Jack Estro that was published earlier this year in the Red Journal. that created a propensity score matched cohort analysis, and they found that between a salvage mastectomy or a second lumpectomy with reirradiation, there is no statistically significant difference in local recurrence, regional recurrence, distant metastases, or disease-free survival. In taking a closer look at today's abstract from Dr. Espinoso-Bravo and colleagues compared to the NRG study, we see some similarities both in the design and in the outcomes. So the NRG study was a little bit larger and did not have a lower age limit, but both selected for small breast cancers with a good duration of time between the initial therapy and the recurrence. The NRG study had a slightly higher rate of recurrent DCIS compared to invasive disease and used 3D conformal for all patients. If we look at the outcomes, a median follow-up of 3 years, from the study from Spain, the local recurrence risk was 3%, and for the NRG study, now with 5.5 years follow-up, the local recurrence risk was 5%, so encouraging in the setting of proper selection. There are a few published guidelines or recommendations for who may be eligible, and both the NRG and today's abstract largely fit into these criteria. So out of Italy, there's a publication with guidelines for who may be the best to select for this approach, and also out of Germany, and these highlight these same factors. So it's isolated local recurrence, a small tumor, potentially an older age, and really that duration of therapy spanning 3 to 4 years. So in summary, in regards to the topic of the first abstract of omission of radiation and endocrine therapy, non-adherence can range quite widely, up to 50% in some series. There are risk factors which should, of course, we should be doing this with all patients, but particularly for those who may be at higher risk for non-adherence, that we're really making sure that we're communicating well and the patient's understanding, and they feel that they can report back to us on what's going on so we can help manage those effects. This particular study today showed that there's a high local control with the omission of radiation, and that makes us excited and hopeful for the data from the prospective studies, so we can appropriately de-escalate in the appropriately selected patients. It also potentially brings up the question, what is the role of endocrine therapy in the patients who are having radiation? In this retrospective review, the local control was still 100%. These patients should be at low risk for distant metastases, and what is the role of exploring that further? And then also highlights the importance of tracking adherence, which the DEBRA study does have built into the protocol, as that was realized by the investigators to be a very important piece of information as the outcomes are analyzed. In regards to the recurrent setting in reirradiation following a second lumpectomy, with salvage mastectomy, there still is a risk of local recurrence. Lumpectomy alone is not a recommended option. Those recurrence rates reach up to about 30%. And in this abstract today, the local recurrence at 3 years was 3%. Molecular subtype was not associated with a difference in outcome in this small population that was evaluated. And so this abstract significantly contributes to the increasing data in this setting that may give patients additional options beyond mastectomy for those who wish to preserve the breast. And I appreciate everyone's attention and looking forward to discussion. Thank you.
Thank you, Dr. Bradley. That was outstanding. If our speaker is here, you're welcome to come to the microphone in case there are questions. For everybody watching live, you can put questions into the chat on the virtual platform. We don't have any yet. I have a couple, so I'll toss a few out. You can also do the virtual on your phone, on the app. There's the virtual meeting, and you can go to the Q&A for this session and enter questions that way if you want to. But while we're waiting to see some thoughts for either of you, really, that I was wondering while I watched that, is whether you think it might ever be feasible that if somebody makes the decision to stop taking endocrine therapy, to do radiotherapy then. And I always wonder this in this population of patients, because realistically, if they had cells, they're likely to be quiescent, and if they haven't recurred, they're probably still there being quiescent, and wouldn't you still potentially get the benefit of radiation a year later if you stop taking your endocrine therapy. And I don't know if our speaker's here and wants to comment as well, but I'll toss it to Dr. Bradley.
Thanks, Dr. Woodward. I think that's a really interesting question that I don't know the answer to. I think would have a high value for some people where they start the endocrine therapy, the side effects are significant. They are in some portion of patients. There can be the option of switching to the other endocrine therapies, and sometimes the side effects are less, but sometimes looking at that balance of quality and quantity, it makes sense. The patient's quality of life is so affected. I think there is a little bit of retrospective data that after about 6 months, the efficacy of radiation decreases a little, but that's not specific to this population. I think that's all comers with a wide range.
Yeah,
so.
I think there must be some nuance to that of who might still benefit over time. We have a question in the room.
Chip Cody from New York. Reconservation of the breast has become a pet topic of mine, and we actually reported our experience early last year. And what we have observed is exactly what the European propensity match study showed. Our study did have some case selection. So the patients tended to be older with longer disease-free interval, but the tumor characteristics were very similar between groups, and we observed identical outcomes with mastectomy and breast conservation. So my question for the panel is, now that we're seeing guidelines emerging from Europe, isn't it time for the NCCN to come around with a guideline of their own? I'm not on NCCN, but I wonder if any of you are and might give us your thoughts.
Dr. Thompson, do you want to take that one first?
I'm delighted to hear that you too have demonstrated the feasibility has been reviewed here of not having to go to mastectomy for everyone, and I would completely support you in pushing for those who provide the guidelines to us nationally and internationally to follow what has already been done in Europe. Thank you, Chip.
What we've observed is that more than half of our patients with IBTR are now being treated with reconservation.
Fabulous.
Well, that's great. And I know there is a proposal at NRG to take the 1014 study further and to help put some more prospective data out there that might shift the needle on that. Excellent. Any comments from our virtual speaker, who I can now see is on screen? Maybe no? Oh, perfect. Go ahead. We have another question from the room.
I'm Sing Sol.
Oh, wonderful. Congratulations. Thank you for being here.
Thank you so much for the great summary and, fantastic overview of the endocrine therapy adherence. I just wanted to comment on the first question about how we treat when the patients are expected to, or if they decide to discontinue endocrine therapy after they initially decided to start. I get a lot of questions when I was presenting my poster back there, and I think we don't have a clear answer for that. But just in our own institutions, we still consider going back to radiation therapy if they discontinue endocrine therapy after about 2 months. But I do hear, depending on the practice, some people, like some radiation oncologists, will still treat after 6 months or even after that, considering the locoregional recurrence rate is pretty high if they discontinue endocrine therapy. So I think that's an area of maybe debate or further investigation, and the practice still varies.
Thank you.
Thank you.
We have another question from the room.
Oh, great. Thank you so much. Great presentations and commentary. My name is Dustin Booth. I'm from Intermountain Healthcare, radiation oncologist there. And I just want to touch again on this topic of predicting patients' endocrine adherence, because it's a challenge. I meet with patients and we're excited about sending them on endocrine therapy and omitting radiation, and then we find out a year or two later they stopped, and this abstract and other data suggests that's bad. And so one question I have for you is that you demonstrated some clinical and socioeconomic predictors of success, but how about patients' own prediction of their likelihood and at different time points, either before surgery, after surgery, and 3, 6, 9 months later, whether or not they're predicting themselves, or whether or not they're going to continue through the whole 5 years? and if there's some sort of intervention that people are doing based on patient self-assessment and using that to help counsel patients. Thanks.
That's a great question, and I didn't come across that specifically when I was reviewing the literature for this presentation. I think often patients want to be very committed at the beginning, and then if the side effects develop, it becomes that much harder. In general, from the papers that really looked at the patient's subjective approach, there was a sense that it wasn't asked about, that maybe the visit was somewhat rushed. And one comment from this nursing study was they didn't even take it off they didn't ask me if I was taking it, didn't take it off my med list, and just assumed that I still was. And so perhaps building into the clinical workflow, through nursing, even maybe a good, or sometimes health coaches, that's becoming more common in primary care for managing diabetes, and ways to keep track and maybe building in time to really address the range of symptoms. I know sometimes sexual function symptoms are not as asked about because it's a little less comfortable, and making that environment as friendly as possible or open as possible to bring those things up. But that would be an interesting prospective study is, do you, at this point, 1 year later, do you intend to continue? And most of the graphs do look like it's a steady decline over the 4 to 5 years. So for whatever reason, it's not like everybody drops at once and then it levels out.
It is a great point, though, and one of the reasons why it just makes me wonder if we counseled folks up front, hey, if this doesn't work out, feel free to reach back out to us. We could think about the pros and cons of radiation later. Might be a way to help keep a few more folks in that safety net. Super. Any last questions on this group? And if not, we'll move on. So our next